TIVA, what's now and what's new. The concept is to talk about where we stand in terms of total intravenous anesthesia now. And that's the reason I will not take you to the history of TIVA because we are going to be more practical in this discussion. So total intravenous anesthesia is defined as a technique of general anesthesia using a combination of intravenous anesthetic agent given exclusively by intravenous route without the use of any volatile agents. The advantage that we have when we use total intravenous anesthesia is smooth and predictable induction, reliable and titratable maintenance, and a rapid recovery with fewer complications. This leads to early discharge. It also reduces the postoperative agitation and also reduces the incidence of PONV. It also induces low neurohumoral response, which leads to better hemodynamic stability. It preserves hypoxic pulmonary vasoconstriction and hence improves the ventilation perfusion mismatch. It also provides better intracranial dynamics and preserves cerebral autoregulation. Along with this, it has got very less environment pollution effect. It offers us a basket of advantages. So when we think of TIVA, we need three basic things: a drug which fits into the requirement of TIVA, a device to administer that drug, and a monitoring system to monitor the depth of anesthesia. There are multiple pumps which are available in the market, we all know, which are specialized TIVA or TCI pumps from different companies. And there are different depth of anesthesia monitors, especially when we're using TIVA, like bispectral index, we have SEDline, entropy, and Conox is also there. And there's a various drugs which we use. We all know that we can use combination of propofol, opioids, dexmedetomidine, ketamine, benzodiazepine, and other agents. So all these three things eventually we'll see in detail. So when we talk about TIVA, bandwidth varies from sedation to general anesthesia. Depending on the situation, how are planning the anesthesia, the airway management will differ from whether we use spontaneous ventilation without any device, or we may use airway adjuncts like oral or nasal airway, or laryngeal mask airway, or we can use endotracheal tube. So it provides a possibility where we can use a single drug. For example, we can use propofol if you're using moderate sedation, or we can also use dexmedetomidine or fentanyl, or we can have combination of different drugs. This will help us to reduce the requirement of drugs and to provide balanced anesthesia and also reduce the complication of individual drugs. Before we move ahead, we need to understand something called as three-compartment model. So when we inject these intravenous agents into the bloodstream, it gets distributed into the central compartment, that is plasma. It goes to the muscles, that is second compartment, and goes to the fat, which is the third compartment. And we need to achieve an equilibration before it reaches its peak of equilibration in the brain. The brain here will be defined as the effect site, and the plasma will be the central compartment. So this is a three-compartment model. And to achieve a constant level, we also need to consider the drug administered on one side and the drug getting eliminated on the other side. So this compartment, though it is very theoretical, help us to imagine what is happening with the drug that we have administered and how it is achieving its effect. Now coming to this very famous slide where we have anesthesia drugs used over 8 hours and look at a context sensitive half time. So in this, if we see fentanyl, what happens after 3.5 to 4 hours, that fentanyl context sensitive half time reaches to the peak of 300 minutes, and this indicates that there will be significant accumulation. The same effect is seen with the thiopentone and midazolam over 8 hours. But if you look at the two drugs which are given at the base, remifentanil, which is in blue color, and the propofol in yellow, the context sensitive half time is very minimum. And that is the reason it becomes very ideal to use these two drugs when we are using total intravenous anesthesia. So when we think of ideal drug for TIVA, what we expect is the drug should have rapid onset, should provide a rapid recovery, should be potent and lipid soluble, should be a stable solution with no perivascular sloughing if it is extravasated. It should be water soluble to minimize the toxicity associated with the solvent, should not be absorbed by the plastic, be devoid of adverse effects, and it should be cost effective. What are the indications of TIVA? So as we know, it all started with two things. One is tubeless airway surgery, and more than that, the neurosurgery. Because we know the total intravenous anesthesia has more favorable effects when it comes to the intracranial dynamics. So along with this neurosurgery, application was further increased to neurophysiological monitoring, where we want muscle relaxations to be avoided when we are monitoring motor evoked potentials or sensory evoked potentials. The indications now are not limited to this, but each and every patient who undergoes anesthesia where general anesthesia is to be given, TIVA can be applied. Significant key points for us to understand is malignant hypothermia, severe PONV, neuromuscular disorder, difficult reactive airways. So these are the key indications. Also can be useful when we are transferring a patient, when we are in a remote place where we are giving anesthesia. Can be useful in ICU, especially helpful in where there are environmental concerns, may reduce the cancer recurrence. Coming to the drugs that we use, propofol, which remains the principal drug for total intravenous anesthesia, which is a short-acting hypnotic agent, acts on GABA receptors, widely used to induce and maintain intravenous anesthesia, has a rapid onset and a rapid offset, and allows smooth transition during perioperative period. As it lacks the analgesic property, so opioids are usually used along with propofol. However, propofol can be used as a sole agent for moderate sedation. One needs to be careful about propofol infusion syndrome when it is used at a very high dose for prolonged duration, that is more than 5 milligram per kg per hour for more than 48 hours, where it can lead to metabolic acidosis, rhabdomyolysis, liver failure, and myocardial failure. Coming to opioids, as we know, it binds to the opioid receptors centrally and peripherally and modulates the pain perception. It is used in TIVA to provide analgesia and also to supplement the hypnotic effects of propofol. Fentanyl and remifentanil are currently being used. It reduces the requirement of additional analgesic during and after surgery. Administered as a continuous infusion or titrated intermittent boluses also reduce the requirement of the propofol. As we already seen, the context-sensitive half-life for fentanyl is much longer and may cause delay in the emergence. And remifentanil is an ultra-fast-acting opioid, easily titratable due to its rapid effect site equilibration. It has fast onset and offset and short context-sensitive half-life. And remifentanil is effective in reducing the propofol requirement by almost 40%. Disadvantages includes respiratory depression, potential postoperative hyperalgesia, and thoracic wall rigidity. Coming to dexmedetomidine, which is a selective alpha-2 agonist, it is a sedative, anxiolytic, and analgesic agent. It causes less respiratory depression. It has got opioid and anesthetic agent sparing properties and improved hemodynamic stability. It can also be used as a sole agent, especially for sedation or moderate sedation, and can also be used as a sole agent for awake craniotomy. Coming to ketamine, which is an NMDA receptor antagonist, which is a sedative and an analgesic also. Advantages include it has got less respiratory depression, causes bronchodilation, it provides excellent analgesia, maintains sympathetic tone, resulting in improved hemodynamic stability, and this property can be useful when used wisely and carefully in critically ill patients or patients with cardiac comorbidity. The disadvantage includes it increases airway secretions, can cause nausea, hallucinations, and interference with processed EEG monitoring. Other adjuncts which are used along with these agents are midazolam, magnesium sulfate, lignocaine, dexamethasone, paracetamol, and NSAID. Regional anesthesia or selective nerve blocks or the facial plane blocks can also be used to enhance the perioperative analgesia. So these are the different boluses that are used, especially when we are using manual infusion. For propofol, as we all know, bolus is 1 to 2.5 milligram per kg, followed by a maintenance 6 to 12 milligram per kg per hour. Obviously, this is reduced when we use opioids along with this. So we can use fentanyl 1 to 2 microgram per kg bolus, followed by 1 to 2 microgram per kg per hour, but in longer surgery, that needs to be reduced further after 2 hours. Remifentanil, 0.5 to 1 microgram per kg bolus, followed by 15 to 30 microgram per kg per hour. Dexmedetomidine, 0.5 to 1 microgram per kg, followed by an infusion of 0.2 to 1.2 microgram per kg per hour, depending on patient and the procedure. And ketamine, 0.5 to 2 milligram per kg bolus, followed by 0.25 to 1 milligram per kg intermittent boluses as and when required. So these drugs can be mixed together and can be used as in the single syringe. So different mixtures that has been tested and approved is ketofol, where we use 1:1 ketamine and propofol, ketodex, where we use ketamine and dexmedetomidine combined, ketomade, where ketamine midazolam can be combined, or we have ketamine propofol dexmedetomidine, that is KPD mixture. There is midazolam fentanyl and dexmedetomidine mixture, propofol dexam and fentanyl mixture, And currently, what is getting more popular, especially when it comes to TIVA or TCI, is P mixture, that is remifentanil and propofol, where 1 milligram of remifentanil is mixed in 20 ml of propofol. So it gives up 50 microgram per ml of remifentanil and propofol in the standard 1% concentration. So now coming to the technique and models of TIVA. So TIVA can be introduced as intermittent boluses, as we all have been doing, especially in outside OT setups like endoscopy or radiology suites, where we use intermittent boluses of ketamine or fentanyl or propofol, depending on the scenario. We can also use fixed rate infusions, so that is time variant, or we can use dose variant infusions. So simple conventional syringe pump infusion pumps are used for this. And against this, we have better syringe pumps, which are called as target control infusion syringe pumps. So coming to the manual infusion for propofol, if we see in adult patient, Bristol model was recommended and it is still being used where ECI or TIVA pumps are not available. So we use propofol in a dose of 10 milligram per kg per hour for 10 minutes. This is after the induction dose of 1.5 to 2.5 milligram per kg, followed by 8 milligram per kg per hour for 10 minutes, and thereafter it is 6 milligram per kg per hour. With this, the blood and brain concentration for general anesthesia achieved is expected to be between 1.3 to 6 microgram per ml, and our average standard target is 3 microgram per ml. So disadvantages of manual infusions are neither the estimated plasma propofol concentration nor the effect site concentration can be displayed on the pump screen, which is seen in the TCI pump. The frequent changes of the drug infusion rates are required to maintain a constant plasma propofol concentration, especially if the surgical stimuluses are added in between. Any desired increase in the target plasma concentration requires manual bolus, or any decrease in the target plasma propofol concentration requires infusions to be reduced or switched off for a short period. So this creates a lot of ups and downs in the plasma concentration. So to have a more controlled and more effective plasma concentration, target control infusion system has been proposed and been used for more than 2 decades now. The accuracy of the intravenous drug administration can be improved by use of TCI system. It actually facilitates the administration of reasonable and stable concentration and facilitates a rational titration of drug plasma concentration during the procedures. So these are the systems which are computer-driven infusion pumps with pharmacological models incorporated into the software. So TCI system calculates the bolus and infusion to achieve a specific plasma or effect site, that is brain target concentration, considering the simultaneous pharmacokinetic processes, the distribution, elimination, clearance from the body. So these pharmacokinetic models are derived from extensive clinical data and describe specific intravenous agents absorption, distribution, metabolism, and elimination. For several anesthetic drugs, different models have been proposed. The performance of these models, their precision, variability, and bias can be compared using Warwell criteria, which we'll be discussing eventually during our discussion. So different models that we have for propofol, we have Marsh and Snyder for adult, and Kataria and Pedifusor is for pediatric patients. Elevel is a new model, which again we'll discuss in next couple of slides. And there are other models, including Morse and Hannibal Collin model for the dexmedetomidine, which is now coming into the clinical practice. Specific cohort of the patients related to the total intravenous anesthesia. First is obese patients. If we are using TCI in obese patients, the pharmacokinetic models which are available currently are likely to be inaccurate. So if we use Marsh model, it can only be programmed up to the weight of 150 kg, and Snyder model will be acceptable only if the BMI is less than 35 in female and less than 42 in male patients. There remains a lack of evidence on whether one should use the actual body weight or the ideal body weight when we are using TCI. So there is a gray zone, and current advices have been produced in accordance with the Society of Obesity and Bariatric Anesthesia, which recommends careful titration to clinical effect, and they strongly recommend use of processed EEG monitoring like BIS or entropy in obese patients. Coming to pediatric patients, TIVA in pediatric is a growing concept. It provides number of advantages like reduced PONV, decreases emergent delirium, which is very common in pediatric patients, and reduces airway reactivity. TIVA is difficult to standardize when compared to adults in pediatric patients because of the pharmacokinetic and pharmacodynamic variations and practical differences across the various age ranges, and requires specific knowledge and training to allow its safety for the pediatric patients. So the two most widely used models that we already discussed is pedifusor and Kataria. So pedifusor is a variant of Marsh model, which is suitable for children between 1 to 16 years of age and who weigh between 5 to 61 kg. And Kataria model is suitable for children between 3 to 16 years and who weigh between 15 to 61 kg. Both models target plasma propofol concentration will again be standard, that is 5 to 6 microgram per ml. Coming to the pumps, so there are different pumps that can be used to administer TIVA. Manual pump where we use routine conventional infusion pumps, and TIVA TCI pump, which are advanced syringe pumps with pharmacokinetic models. Whether we are using manual pumps or we are using TIVA TCI pumps, we preferably should be using specialized IV connectors. So coming to the TCI system, these various pumps can be used, where we have single pump, single syringe pump, or we can have a pump with attachment of possibility of 2 pumps or 3 pumps. There are different controls for these syringes. Coming to the conduct of TIVA and safe TIVA practices. So when it comes to conduct of TIVA, if we look at the top, there is a specialized connector. So when we see these connectors, at the top, what we see is an anti-reflux valve where the fluids are connected. So the drugs that we are giving from the other end should not have a backflow into the IV line. So we have a specialized valve there. And then there's an anti-siphon valve, which are used at the drug delivery ports. These kind of connectors should be used for the safety and assurance of adequate delivery of standard concentration of drug and avoiding any dilution with the IV fluids used. Coming to IV lines, keep these IV lines where the drugs are being administered possibly visible. The specialized anti-reflux valves and siphon valve connectors should be used. It should have minimum dead space and flush dead space to at the end of the case so that it won't cause any effect recovery of the patient. Coming to the infusion pump functions should be ensured that they are functioning correctly. It should be programmed for the specific patient, drug and syringe, and correct drug concentration should be used. Correct drug should be mounted in the current pump. There should not be any confusion over that, and pressure alarms appropriately set. Coming to the effect site monitoring, one is processed EEG monitoring in terms of base or entropy, and clinical monitoring in terms of heart rate, blood pressure, and other basic clinical parameters. These are guidelines which are proposed recently for safety of practice of TIVA, where they recommend that all anesthetists should be trained. These are very simple, and we feel that why we are reading this, but if we follow this, we ensure very safety of the patient, specifically if we are using TCI. So all anesthetists should be trained, especially when we are using TCI. When general anesthesia is to be maintained by propofol infusion, use TCI preferably, especially in cases like neuroanesthesia. Starting target concentration should be chosen depending on the characteristics of the patient, co-administered drugs, and clinical situations. Within an anesthetic department, it is preferable to stock only one concentration of propofol. We can't have 1% propofol, 2% propofol, because if we mistakenly aspirate 2% and set up the pump for 1% propofol, it can lead to fatal events. The infusion set through which TIVA is delivered should have a lever lock connector, which we have seen, with anti-siphon valve and anti-reflex valve. Drug and fluid line should be joined as close to the patient as possible, and the use of administration set specifically designed for TIVA is recommended. Infusion pump should be programmed only after syringe containing the drug to be infused is being placed in the pump. The intravenous cannula or central venous catheter through which infusion is being delivered should be visible throughout anesthesia. Use of processed EEG is must, especially when we are using neuromuscular blockage, because we may miss out lighter planes of anesthesia when the patient is paralyzed. And when the TIVA is administered outside OR, the same standard of practice that we just discussed must be incorporated. If we talk about so many advantages of total intravenous anesthesia, what are the disadvantages? What we need is a dedicated venous access. Patients may have pain on injection. Risk of bacterial contamination in prolonged surgery is there. There is no current availability of inline continuous monitoring of blood concentration of drugs that we're giving. Delivery problems may go unrecognized and cause serious problems in the surgical setups. We need specialized equipments like infusion pumps. There's a less training available for TIVA technique currently, metabolism for clearance. So we depend on the body systems for that. Potential for disconnection is there and can cause lighter planes of anesthesia, which may lead to risk of awareness. So this is where we stand currently. Let us see where we are heading, what is new. So we have newer drugs like remimazolam, ciprofol, fospropofol, intermediate analog is also being processed. So if we look at these newer drugs, which are supposedly have wonders in total intravenous anesthesia, remimazolam, ciprofol, and fospropofol, they have crossed the clinical trial stage 3 and they are ready for approval. And the other analogs and derivatives are in the first and second phase of the clinical trials. Coming to remimazolam, which is promising for procedural sedation and anesthesia. It is pharmacologically a benzodiazepine, but it is differentiated by ester group and leads to rapid metabolism by tissue esterase to a significantly inactive or less active metabolite. Its rapid pharmacokinetic and dynamic with relatively small effect on covariates such as age, gender, race, obesity status, physical status, and weight will make it a perfect addition for TIVA medication regimen. Ciprofol, which is again a GABA receptor antagonist, it is novel 2,6-di-substituted phenol derivative like propofol with improved pharmacokinetic and dynamics. It has rapid rate of onset and recovery in preclinical experiments. It is 5 times more potent than propofol, does not cause pain on intravenous injection, provides better hemodynamic stability, better in prolonged infusions due to rapid clearance, can be given in initial dose of 0.4 milligram per kg for 30 seconds, followed by 0.1 milligram per kg for 10 seconds, and maintenance infusion is 0.1 to 0.3. So this is in the clinical trial settings. Coming to new PKPD, that is pharmacokinetic pharmacodynamic models for existing anesthetic drugs for TCI. So we saw the new drugs, now the new models for the existing drugs. So this is the Warwell criteria that we heard about. So it is a multi-step process where we look at the bias of pharmacokinetic and pharmacodynamics, precision and variability. We compare with the overall outcome. So when the MDP is less than 20% and MDAP is less than 40%, it is suggested to indicate clinically acceptable performance. This is a comparison of different patient sets of biases, variables, the different models that we have. Coming to Marsh and Snyder, both are published as a TCI model for adults and Kataria and Pedifusor for children. But now we have a unique model, which is an A-level model, which is derived from the direct patient data. It is not dependent from volunteers data. It is a first general purpose model, which can be used for children, adult, older subjects, and even for obese. So this is something which is new. And this model is now available in the current pumps. Coming to the closed loop TCI, so it is also known as feedback control system. It is an emerging technology where we use real-time monitoring in terms of BIS or entropy. So it ensures precise control of anesthesia. It's a direct feedback system. Human interference is minimized. And it ensures the patient remains adequately anesthetized while minimizing the risk of underdosing or overdosing. So MaxLipi is the first automated closed-loop anesthesia drug delivery system, a kind of anesthesia robo. It controls the 3 components of general anesthesia. So it uses bispectral index for hypnosis, analgo score for analgesia, phonomyography for neuromuscular blockade. Kind of a first robo automated system. This is another robo system, a diagrammatic presentation of the MaxLipi. This is closed loop, a TIVA system with SedLine. Again, the same system. So what happens in both these systems is we are using depth of anesthesia monitors, which is connected to the TCI pumps. So there is a direct feedback given to the TCI pump, and the flow rate of the infusion is adjusted depending on BIS. So if you're using, for example, BIS or SedLine, and if we want to target levels between 40 to 60, then infusion pump will be directly linked to the these processed EEG feedbacks, and the infusion rates are directly automatically adjusted to achieve adequate depth of anesthesia. This is another robo, which is a eye control RP anesthesia robo, where both propofol and remifentanil. So RP is for remifentanil and propofol. So this is kind of another robo that we have in process now. We will see what is actually happening when we are using these systems. So this is a 2020 article which is published in Anesthesia Journal, comparison of predicted and real propofol and remifentanil concentration in plasma and brain tissues during target control infusion. It is a prospective observational study. So what they did, they included 38 adult surgical patients, and then they divided between the patients who are undergoing surgery for epilepsy and tumor resection, and only the epilepsy patients, which are around 19 patients, were included. And they took the sample of excised brain tissues, which is normal brain tissue, collected an arterial blood sample, and predicted plasma and effect site propofol and remifentanil concentration on the syringe pumps were also read and compared. So this is the first kind of study where blood and brain concentrations were measured at the same time. And this gave some insights into how the TCI pharmacokinetic models are working. This study, which is a very small study, but this is a very important study because for the first time we are looking at what we see on the pumps screen and what is happening with the patients, not only in plasma but brain. So for remifentanil, when Minto model was used, it showed significant underestimation in the plasma and overestimation in blood concentration, and Marsh model overall underestimation of propofol concentration, which was higher in brain as compared to the plasma. So this study throws a light and says that there is a conflict which shows that the effect site concentrations of anesthetic drugs during equilibration cannot be assumed to be equal to the plasma. So probably a lot of future studies will be based on this study and will probably help us in redefining the models for TIVA and TCI. Another study, which is again related to the automation of anesthesia, a review on multivariable control. What it says that regulation of anesthesia is indeed a multivariable problem. So it is trying to tell us where we are heading. So control of anesthesia cannot be done based on the feedback of a single measurable out. It is multivariable. So several challenges are discussed in this paper, which includes model uncertainty, controlled variables, closed loop application, and our dependability on all this. And definitely it is a very complex challenge to automatize anesthesia. And it says that, so this is a 2020 article again, and it says that we may not be ready with automation of anesthesia for another 20 to 30 years. But with increasing reliable measures on robust adaptive control system, probably that may happen little earlier than this. So where we stand currently, what I would like to say to conclude is, let us start to use TIVA whenever it is possible. Maybe after this presentation, we can have question and answer session where we can change our experiences. For us to see the change, let us be the change. Start with selective surgeries. As a supplementation to regional anesthesia can be used, and we can start it with available resources. We need not wait for the more modern techniques. And propofol, ketamine, fentanyl, dexamide is easily available with all of us, and we can start with that. And obviously, remifentanil is now in coming and we all have started experiencing it. There are certain apps which we can use to understand how the TIVA works. It's like iTIVA Plus or Anesthesia Infusion Calculator, IV Calculator, TIVA Manager, or TIVA Trainer. So, this is just to, have understanding how TIVA can be used. Study materials can be used from the society websites for TIVA, which is Euro SIVA or World SIVA. Then we have SIVA website. Then we have Association of Target Control Infusion and Target Intravenous Anesthesia. These websites will also help us, getting some information about how to use TIVA effectively. To conclude, my take-home message is TIVA is effective, safe, and reliable technique. It has many advantages over current practice of volatile anesthetics. Ongoing research will change the way anesthesia is administered in future, and probably TIVA may become the technique in future. However, the current form of TIVA itself is very promising in terms of all stated advantages and patient outcomes. Addition of remifentanil in our armamentarium will make practice of TIVA more attractive. All anesthetists should learn, acquire, and propagate this technique. The safety norms prescribed by various guidelines must be followed to ensure the patient safety. Thank you.